Alright, hey, is this there before? Okay, so intestines. So same problem when you're looking at disorders of motility. If you're not getting flow going through, there's got to be a problem. And when you're looking at intestinal obstructions, it can be all kinds of things. It can be from a bald hair. So people that have, I'm having a brain fart in this disease, trichotillomania, where they pluck the hair out, and then trichotillophagia is when they do what? Think about the word. They eat it. They pluck it out and then they eat it. And then the hair is so dense, you can't digest it properly, so it starts accumulating. It's basically a hairball. But when it accumulates and it blocks up the GI tract, it causes lots of problems. So a typical or generic word is an ileus. If you have an obstruction of the intestine, it's an ileus. So a hairball is a good one. Yep. So paralyzed intestine can block up flow too. Okay, and then peptic ulcer disease. It doesn't have to be just the stomach, it can actually be anywhere down in the intestines. So if it was a gastric ulcer, typically it's pointing right at the stomach, but when it's a peptic ulcer, it can be anywhere along the GI tract. So it's kind of a generic term. If they say it's a duodenal ulcer, it's telling you exactly where it's at. What segment is that? Duodenum? Duodenum. Yep, and then there are pictures down here. You see the erosion of the wall. It's actually penetrating through it. And then another common cause is because of Helicobacter pylori. That's the bacteria again. So how do they treat that? Yeah, just give them an antibiotic. Like I was saying, in the early 1980s, they laughed at the guy that said it was probably a bacteria, but when he started extracting from people that had really bad breath, halitosis, he went, well, there's a bacteria there. They started treating them with antibiotics, and these people kept getting better. Their ulcers were getting better and everything. So they said, whoa, actually it is. But there are lots of causes. So taking anti-inflammatory drugs can actually affect the wall of the lining of the GI tract. A lot of times it can be either because of the chemical itself, or it can even be because of the lining on the outside of the pill, which is made out of what? Take a guess. What protects that pill from being destroyed in the stomach normally? A base. Yep. So they're lined with bases. If you put a pill on your tongue and it tastes really bitter, it's activating base receptors, bitter receptors on your tongue. If it tastes really sour, it's activating what? An acid receptor. Yeah, so when you put something on your tongue and it tastes really bitter, like you're chewing a cigarette, that's a base. Did you know what I was talking about? Have you had that taste before? Oh. You're like, ew, gross, chewing a cigarette. I remember that.
Just the thoughts.
Right, it's the nicotine. But then there are those people that, especially I've seen it in Iowa, where they put the stuff in their mouth and then they spit it into a soda bottle. And the only way you know what that is that it's dark and it's in a Mountain Dew bottle. So, and yeah, and their lips poking out. Whew. They think they really. Oh. Yeah, nasty.
Yeah.
What are you having there, cotton candy? Whoop. Okay, so lots of different causes, and a big contributor is actually just acids in general. Should it be very acidic in the duodenum? No, it should be actually slightly basic. What's the name of the organ that actually makes the duodenum slightly basic? The pancreas, right. So if somebody's having pancreas issues, they may get more duodenal ulcers because they can't neutralize stomach acid. Yes. When the chyme moves on through with the stomach acid, they can't neutralize it. So, and I keep trying to point little things out. When you have a symptom, does it always definitely for sure say what the problem is? No, if you have a duodenal ulcer, does it have to be the duodenum? Nope. It could be hypersecretion of something in the stomach. It could be because your pancreas isn't working appropriately. There are lots of different causes. Okay, and then malabsorption syndromes. The primary place that you absorb nutrients is in the, what part of the intestine? What part of the small intestine? The duodenum, yep. So even though it's only about 8 inches long, of the 3 groups, it's the shortest one. It actually has the most absorption and the most digestion. And when you think about it, the 2 major accessory organs, the liver and the pancreas, they both secrete down the common bile duct and then down into the duodenum. The duodenum has the enzymes that break apart proteins, enzymes that break apart fats, enzymes that break apart carbs. It's there to make sure you're breaking down everything that you didn't break down in the stomach or the mouth.
But protein does start in the stomach.
Yep, it starts in the stomach. And then carbs actually start in the mouth. Okay, so maldigestion means you can't break things into their most simple components. Like a carb is a polysaccharide. What do you have to break it into to absorb it? A monosaccharide. Triglycerides have to be broken into monoglycerides and fats. Proteins get broken into amino acids. Can anybody think of a maldigestion problem that people have that's really common, actually, where they can't break apart disaccharides into a monosaccharide? It's lactose intolerance. Yeah. Lactose intolerance is an example of maldigestion. They can absorb just fine, but they can't break the sugar down into simple forms. And then malabsorption is where they can't actually get it across the intestinal lining. So there's a difference between those two words. Okay, so malabsorption in this situation, so pancreatic insufficiency, if you're not releasing the appropriate enzymes, you're not getting malabsorption, which, by the way, technically, what are you not doing to those foods? Digesting them. The pancreas releases enzymes to break apart carbs, proteins, and fats. You need those. If the pancreas isn't working properly, what's going to happen to your digestion? Down. What happens to absorption if digestion goes down? Goes down with it. So lots of causes. Look at the way it revolves around the pancreas. Pancreatitis, pancreatic carcinoma, cancers. What's cystic fibrosis? They make too much, well actually I shouldn't say they make too much, but they have too much what? Mucus, yeah. Anybody remember what caused it? It was genetics that we talked about it. Cystic fibrosis, they have a little tiny transporter for chloride that doesn't work. They can't transport chloride, so sodium and chlorides build up in the mucus layer and cause this real thick, sticky mucus. See if you remember this guy named Fick. Fick had his laws that defined what? Fick's laws of diffusion. So in your GI tract, to absorb it, you have to get it to the wall. What happens if you get really thick mucus? What did Fick say about diffusion? It's slower. It takes longer to get it to the wall, which means you're less likely to actually diffuse it, absorb it, and get into your bloodstream. Remember, your GI tract keeps moving it. It's like a flowing stream. It just keeps moving downstream. To get a hold of things, you actually have to get them to the wall as they pass downstream. Let's see. And then fat maldigestion is a big problem. So not breaking down fat, because fat interferes with everything. Fat sticks to the walls, which is the same idea as actually making that mucus layer thicker. Back in it must have been the early 90s when they came out with this stuff called Olestra, and they started putting it inside of foods because it's half fat and it's half sugar. It tastes sweet, but it also gives a texture like fat, but you can't digest it. So can you absorb it? Nope. And it's fat-loving, so it's stuck to the walls of your GI tract, and it would actually creep downstream with the GI tract flow until it actually leaked out your anus. I'm not talking about the planet. But does anybody remember that stuff? They put it in potato chips, and then they actually had to put a label on the side that said this product may cause anal leakage. Yeah. I didn't eat chips very much before that, and I quit at that point. I was like, yeah. Do they still have it? Yeah, I just eat the fatty stuff. I don't want to take a chance at that because basically it's a lubricant. It's just going right through and lubricating the pipes and letting everything slide through. But it's the same problem here. Okay. And then lactase deficiency. What would lactase be? An enzyme. It's an enzyme that breaks apart lactose. And the reason that they get these problems, when you think about it, it's a sugar. Normally you absorb all the sugars that go in as long as you break to a monosaccharide, but the sugar stays intact. It goes all the way through their small intestines. They can't absorb it. It's a solute. What's it attract? Water. It attracts water. And then when that gets down into the large intestine, they can't absorb it there, but it's still attracting water into the large intestine. So what's one symptom they're going to get? Diarrhea. They get diarrhea as a result because there's too much water in their feces. The second thing is that what's hanging out in the large intestine that outnumbers you 10 to 1? bacteria. And it's waiting for sugars. When the sugar gets down in there, they eat the sugars and make methane gas, which, by the way, is flammable. So if you ever wondered if a fart's flammable, it is. So methane gas, and it starts expanding their large intestine. How do they feel? Bloated. They also get flatulence gas. So when you look at what's happening there, it's all because they can't break down sugar. It attracts water, causing watery stools, and it also lets the bacteria eat on the sugar, causing methane gas buildup and distension of the large intestine, causing that bloating feeling. And the type of diarrhea it causes is called osmotic diarrhea because it's primarily water. Bile's there to break apart. Anybody remember? Why do you have to have bile? It emulsifies fats. Where's it made? The liver. Where's it stored? In the gallbladder. So can you live without a gallbladder? Yes, but you have to change your what intake? Your fat intake. Yeah. So this is just a review of it. What happens is you take you take bilirubin, which is from what? Blood. It's a breakdown product of red blood cells. And then you take cholesterol, you put them together in the liver, and the liver makes this stuff called bile that it releases into the duodenum that helps you emulsify fat. It doesn't digest fat, it just separates the fat from a big wad into little tiny, tiny particles. And then you have to release lipase to break apart the lipid to digest it. So bile salts, if you're not getting enough of them, you can't process bile or fat appropriately. The fat goes down in your large intestine. Do you absorb it in the large intestine? Just water and some salts, and that's it. So once the fat's down in there, it just slides right through and gives you loose stools. Why would it affect this? If you don't have enough bile salts, why would you have lots of fat-soluble vitamins like A, D, E, and K? Because, yeah, they stay in the fat that you're passing through your intestine. When you absorb fat normally, you pull them out with the fat. So if you can't absorb them and you just pass through your stools, you lost those important nutrients. And then there are the 4 main vitamins. Can you overdose on any of these? You can overdose on all 4 of these. Can you overdose on vitamin C and B? No. Why not vitamin C and B? What makes them different from these 4? They're water soluble. So how long do they stay in your body? Not very. If you want to test that, take 1 B vitamin, wait a half hour, and take a leak. What happens? It's like neon glowing yellow. Extremely yellow because you just urinated it all out. But here are some of the problems. So if you don't get enough vitamin A, night blindness. Which always makes me think of rabbits, right? If carrots are so good for rabbits' visions, why do you see so many dead rabbits in a row? Did they not see the car coming? Ever wondered about that? So vitamin D, you know about vitamin D. Where's it made? In the skin. Where's it activated? 2 organs. Liver and the kidneys. Yep. So any of those 3 situations, lack of sunlight can cause vitamin D deficiencies. Liver failure or kidney failure can actually cause it too. And then vitamin K is important for blood clotting. And if you're not getting enough vitamin K, you can get purpura and pt2. Anybody know what those are? Yep, they're little capillary bleeds. And the only difference is the size. And then vitamin E, we're still not completely sure what's going on with vitamin E, but we know it is an antioxidant. It's really important for health, like healing factors, decreasing toxins in your body. But if you get too much of it, it can also become toxic. And then IBS, irritable bowel syndrome. This is a big question mark because we don't really know exactly what causes it. And there's so many different forms of it that we're having a hard time isolating it. But we do know that genetics plays a big role because if your parents had it, you have an increased risk of having it. Does that necessarily mean it was the genes? What could it have been? Your diet. Your diet. That's my new word for your diet environment. Your diet. Okay? It could be reactions to intestinal flora, which is the bacteria in your gut. And remember, you can get that fecal transplant now, so they find that that's a really good treatment. And if it's because of T-cell response, what kind of disease is it actually? Autoimmune. Okay. Ulcerative colitis, so you actually get ulcers in the colon. So what organ did we just jump to? The large intestine. Okay. So a lot of times it happens in the sigmoid colon, the rectum, and ulcerative colitis increases your risks of colorectal cancers. And lots of possible causes here too. So you think there might be a link with genetics, diet again, having a low diet, and what? What did they say eat more of to decrease risk of cancer? Fiber. And when we talk about cancer, we talked about it before, they think that a lot of the processed foods actually stick to the walls of your intestines, and the toxins in it and the chemicals that are in it cause mutations. You eat fiber, and it's like taking a bottle brush through. See how I'm thinking already? We had a shower yesterday and we got bottle brushes, and I was thinking, cool, this will fit perfect in the test tubes for my spices. I do. My kitchen, I use test tubes for my spices. My drinking glasses are actually beakers. So I know when I want 250 milliliters or something, I know exactly how big it is. My friends love to come over because when we have like movie night or whatever and people are drinking, I have a full chemistry set in my kitchen. Never used in a regular lab. It's always been for my kitchen. So orange juice and vodka and all that stuff can be measured with the appropriate tools, more accurate than that stinking measuring cup. It was fun. But yeah, we got a little tiny bottle brush. I was like, oh, I've been looking for one of these. Okay, so ulcerative colitis. Oh, I already talked about this one. And then symptoms. We already talked about a bunch of these symptoms that happen with the GI tract. But if you have irritation of the GI tract, it has a tendency to move faster. So what's going to happen when you move it faster? Move the GI tract too fast. What's one thing it's going to think of? Diarrhea. If you move the food too fast through it, if you have irritation of the lining, it's telling your GI tract there's something in here that doesn't belong here. Even if it's the lining itself that's the problem, it's going to make the food move through faster. So what's another symptom of diarrhea? What's going to happen to them? If they're moving food too fast through, they get malabsorption, so malnutrition. And then things like bloody stools we talked about before. And then depending on what the cause is, what you treat it with. If it's an inflammation, if it's something just irritating the lining, what do they usually give the person? Think about it. Inflammation, what do you give them to turn it down? Steroids. Yeah. So steroids to turn down the inflammation. If it's a bacterial infection, of course, they give them antibiotics. And then if it's because of the T cells, then immunosuppressives. And then Crohn's disease, another big mystery. Crohn's disease is so many types of Crohn's disease, so I'm not going to make you be really picky, but a lot of times it tells you where it's at. So like ileocolitis is telling you the transition between the ileum and the colon. Yeah. But typically it's idiopathic, which means we know, we feel like idiots because we don't understand the pathology, we don't know squat. But what they are finding are things like this fecal, I'm all about this fecal transplant today, I'm just obsessed with it. So things like the fecal transplant, they're finding that by just doing that, it's turning down the symptoms of Crohn's disease and helping people get by it. So it must be related to what in their body? The bacteria. So we know there's definitely a link with the bacteria. There can be genetic factors like the way that their GI tract is designed. Maybe they have weaknesses and flaws, but we definitely know that one of the common problems are bacterial issues. And then like I said up here, you don't need to, I'm not going to make you know the different specific types, but typically they just talk about where at in the GI tract it is. Like the first one is at the colon. Ileocolitis is the transition, etc. Right. One of the characteristics that helps them identify it, so when they send the endoscope in there and they look around, they have these little things called skip lesions, and they're little patches. They're little inflammatory patches. I should find a picture and put it up there, but it's one of the identifying markers for Crohn's disease. Because you can't take a blood sample and say, oh, we've got Crohn's disease. You actually have to diagnose it by physical symptoms. And then here's another one. We talked about this before with the stomach. If you have a gastrectomy where you took part of the stomach out and you don't have intrinsic factor, what disease do you get? Anemia. But the other thing is that you can eat lots of vitamin B12 if you can't release intrinsic factor, there's a problem. But what do you have to do with the intrinsic factor and the B12 once you've found them? You have to absorb them, and they're absorbed in the ileum, which is where? In the small intestine. So if you have damage to that part of the small intestine, the ileum, then it reduces your ability to absorb B12 and intrinsic factor, causing what? Anemia. And then folic acid we'll talk about when we talk about the different types of anemia, cardiovascular stuff. And I think it's next week. And then how you treat it based on what they think the problem is. So they usually give antibiotics and see if it goes away, and if not, then they start doing steroids. If they think it's because of an autoimmune issue, then they give them an immunosuppressant. Diverticuli are these little tiny pockets. So here you have your colon, and then you got these little pouches to go along with. What sucks about this is that sometimes these little pouches are big enough that something like a seed can slide in it, like strawberry seeds. They're small enough they can slide in here. They get in there, they irritate the tissue, cause inflammation, and then they call it diverticulitis. Right, so diverticuli are the little out pockets, diverticulitis is the inflammation, and then the asymptom part of the disease, asymptomatic, is actually diverticulosis. So you can actually have the development of this for years causing problems you can't actually see symptoms of. Like it could, what else is hanging out inside this large intestine? It could be problematic. Bacteria. So if the bacteria get in there around the seeds, it's almost like acne. You get bacteria down in a pore and it just goes crazy eating and feeding off of the stuff in there. So you could have diverticulosis and then you could actually get an infection because of it.
That by itself is not normal.
A diverticuli, most people have diverticuli. I don't know if there are people that don't have it.
But it's not supposed to be.
But it's not supposed to be abnormally large. It's just little tiny pockets. And if they get too big, then you get the seed stuck in there or whatever. That almost looks like a watermelon seed, which would be huge, but usually it's little tiny seeds. Like poppy seeds, strawberry seeds. Anybody here know somebody that has it? So the things, what are the kind of things they tell them not to eat?
Strawberries, sesame seeds.
Any kind of little,
eat a lot of fiber.
yeah. And the fiber's same idea, to scrape all the stuff out. That would suck. And then they probably go behind your back and do it anyway. Oh. Yeah, that would cause a problem too. You're not feeling well, what'd you have for lunch? Right, and then appendicitis. So, and an RLQ stands for what? Can you guess? Right lower quadrant. So, the appendix is a vestigial organ. We don't exactly know what it was at one time, but we thought it had a little bit more immune function. And the best theory I've heard of is that the bacteria is all in the colon, but there's not much bacteria in the small intestine, so when the bacteria goes backwards, it's like this is the path of least resistance, and it's getting near to kill. You still have a lot of immune system in there. I just think maybe it's not as big as it used to be. The problem is if that thing pops, what just happened? All that bacteria can go right into the abdominal cavity. So you can get in, start eating at the peritoneum, it's going crazy in there. Are there any other pathways to get straight into like the peritoneal cavity? Usually in women. Well, I don't know why I said usually. In women, it's a specific pathway. So, right up through the fallopian tubes is another pathway into that same area. So either way, easy to get infections in the easy, quote unquote. Easier to get infections in the abdominal cavity through the appendix or up through the fallopian tubes. And then, oops, I forgot the last part there. So, most serious complications, peritonitis, where you actually have the bacteria and causing inflammation in the peritoneum. All right, big slide, just to make it easy. All of the GI tract, all the blood flows up to where? Liver. Yep, all of it's going to flow up, go to the liver, and then from the liver it goes into what blood vessel? Vena cava, and then back up. You have to think about all the passageways coming up through there, into the vena cava, around the liver, from the GI tract. If you get blockages around the liver, you're going to have lots of problems. Because what happens to all that flow? If you have blockages before, inside of, or right after the liver? What happens to all of your circulation coming through your GI tract? It all gets backed up. Yep. So where's it going to back up at? In your abdominal cavity, right? And it's going to cause swelling. It's going to bulge out. And it's going to cause lots of symptoms. If you start increasing the swelling here, it's going to push down all the veins coming from your lower legs. So what things could start popping up on your lower legs? Like you get edema, so swelling up, and varicose veins distended towards the veins, which we'll talk about in the cardiovascular. But you can get varicose veins, even hemorrhoids. So a lot of times when women get pregnant, they get all those symptoms. They get distended veins in the legs, they get edema in the lower body, they get hemorrhoids and stuff like that because this passageway can block up because something wrong with the GI tract is having issues. So the big picture of this vascular insufficiency is you're not getting even flow or good flow from the GI tract to the liver to the vena cava. It can cause all kinds of problems down south, which means just everything below the heart, basically. And I'm not going to obsess about that slide, because we're going to come back and talk about ascites and some of those symptoms like hemorrhoids in just a little bit. So accessory organs, oops, I'm shifting. And yeah, the brain is actually an accessory organ, because does the brain control anything that happens in the GI tract? Absolutely. What system actually does most of the control? So parasympathetic. You want to think autonomic nervous system, the sympathetic and the parasympathetic, and the PNS is actually the primary controller that's extrinsic to the GI tract. So it turns up the GI tract activity. So here's some brain-related or accessory organ-related problems. Obesity is one. And obesity, there's so many causes. So technically, body mass index over 30. Causes can be everything from psychological to genetic and everything in between. It can be environmental, lots of different things. But with obesity, you have to keep in mind that we always talk about it affecting your heart and everything, and it does, and we'll talk about it in cardiovascular, but also your GI tract. When you're getting a lot of abdominal fat, what's it doing to your GI tract? It's actually compressing it, constricting it, right? So it causes flow problems. It can pinch off or create pockets. So it increases the risk of things like cancers and ulcers. So there are a lot of problems that come with obesity. And then the key player with obesity, hypothalamus. What's that regulate? Hunger. Yeah. Freezing, feeding, fighting, fornicating. So the feeding part. Fluid balance, appetite control. And these are just some of the hormones that actually affect it. When we get to endocrine, we'll come back and talk about the importance. But one of the big importance chemicals is called leptin. Leptin is made in adipose tissue. When you fill up your adipose cell, it releases leptin. How does leptin get around if it's a hormone? Through the blood. It goes up to the brain and tells the hypothalamus what? Eat more or eat less? Eat less. Remember, it's a fat cell. When the fat cell's full, you want to stop feeding the fat cell. So leptin comes out, tells the hypothalamus stop. But what has to be on the cells in the hypothalamus for it to detect leptin? Receptors. So they think one of the links is that maybe genetically some people don't have adequate numbers of receptors, so they keep eating, and they still feel hungry. They think maybe there's something about their adipose cells that they're not releasing leptin. So it causes lots of different problems.
And part of it, evolutionarily, would be very advantageous to put on weight.
Yeah.
You almost want to be able to.
Yeah, we didn't store food very well. You know, you store food, it usually goes bad. During the winter, it's hard to find berries and stuff to eat. And even the animals are harder to find because they're hiding or hibernating. So yeah, it was actually advantageous. They find that people that had a more abundant access to foods, we actually had higher metabolisms because we could burn it off. But people that live in places that have very few animals that they can eat off of, they actually have really low natural metabolism, and they store fat easier. So if you take their ancestry out of their environment, put it into a totally different environment, they actually store better. Is that where you're going?
Yeah.
Yeah.
I mean, leptin resistance now is not good, but actually it may have been good, you know.
Yeah, it would have been a benefit a long time ago, right? That's what I like to blame it on. My ancestors, yeah, we lived in starvation environments, and so when we eat a calorie, we're really good at storing that calorie. I'll keep telling myself that until I die. Okay, other accessory diseases or disorders, anorexia and bulimia. Nervosa, they're both psychological. So technically the difference, and man, as I was getting my degree in psych, they started changing the lines of how they describe the stuff. But old school book, anorexia, these people are control freaks. They're over-controlled. They think psychologically there's something in their background that they didn't have control over, so what's the only thing you have control over in your life? You. That's it. So somebody else took that control from them, and their way of getting it back was they were obsessively controlling the way that they controlled their diet. They over-control it. They can look at a piece of chocolate cake. Their brain lights up as if they're addicted. They're getting a thrill out of not eating that chocolate cake. Oh man, it's delicious. They can describe it and say how good it looks and say, nope, not going to have it. Whereas a bulimic, they can't control. They have a failure control. So what are they full of? Regret. So what do they do when they regret what they did? Purge. Yeah, they're both different types of anxiety. But the control is what... When I was learning, most of my teachers were pushing Freud type of things. So mother came into it and everything too. Mother. Tell me about your mother. Right. But bulimia, they lose control and then they overeat and then they chalk it back up. So what kind of other problems would you see with bulimia that you might not see with anorexia? Anorexia is technically they don't eat it. Where bulimia, they eat it, but they vomit it back up. Electrolytes, what? Oh, alkalosis. Dental issues, right. What about esophageal problems, yeah. So you see a lot of problems with above their stomach because they're pushing all this acid up there. You can see erosion of the septum in the nose. You know what I'm talking about. Last time you vomited, you know you got a little in your nose. Okay. So, and then their definition, about 25 to 30% under your average body weight. More anorexia, bulimia, and then their definitions. I'm not going to be super picky. This isn't psych class. Oh, actually that was kind of important. So at the very end, do they just vomit? No, there are two other ways that they lose calories. Laxatives to get through them really quick, which would be like dumping syndrome, and then they also over-exercise. Yeah, they obsessively exercise. So their whole goal is to get rid of those calories, whether it's vomiting, diarrhea, or excessively exercising. You're just trying to get rid of it. With anorexia, usually they have a pretty laid-back lifestyle. They're not real big exercisers. And you can tell by the muscle mass they have on their body. There's like nothing there. Okay, and then starvation. So malnutrition and starvation. I'm trying to think how much detail on this. We already talked about cachexia. What's that associated with? Cancer. Yeah. And then short-term starvation. Here's the problem is that when you starve yourself for short-term, like if you don't eat about every 2 to 4 hours regularly, then your body has to start pulling all of its resources out of storage. What's the organ that usually stores most of your fast energy? The liver. So the liver takes things like glycogen, it'll take stored fats and amino acids and start turning them into, all three of them are turned into forms of sugar. So glycogenolysis, if you look at glycogen, lysis is breaking apart glycogen making sugar. Gluconeogenesis means creation of new sugars. So your liver can actually take fat and amino acids, proteins, and turn them into sugar. But it makes nasty byproducts called ketone acids. So when you sleep through the night, how many hours roughly are you going without eating? It depends on who you are, but on average it's supposed to be around 8 hours, right? Your liver can store about 4 hours worth of food, like sugars and fats and amino acids safely. So that means if you eat not long before you go to bed and you store some food in your stomach for about 4 to 6 hours, when that food runs out, what's going to have to take over? The liver. The liver's going to start spitting out all these sugars in the form of glycogen turning into glucose, fats turning into forms of sugars, and amino acids in the form of sugar. But when your liver's doing it, when you run out of the sugars first, what you start producing as a nasty byproduct? Ketones. what's that last part? We call it ketone bodies or also ketone acids. So the longer you're going through this gluconeogenesis, what's happening to your blood? It's becoming more acidic. Who has to worry about this the most? People that couldn't store the sugar in the first place. If their liver can't store the sugar because they have diabetes, insulin issues, then when it comes to the starvation mode, they can't turn sugar into sugars, the glycogen into sugars, so they have to break down what two things? Muscle, yep, so fat, or muscle, proteins and fats, which means they're automatically making ketone acids, and they crank them out. What do they call that when diabetics have way too many ketones in their body? Diabetic ketone acidosis, or DKA. And usually it happens at what time of day? Has anybody here ever had to deal with somebody with DKA? What time of day?
Well, kind of 2 days. Day.
Oh.
So,
Yeah, the first time I had to do it, it's the most common time that you hear about it, and it was, we got to call it like 7 o'clock in the morning. Why? Why so early? Yeah, she didn't eat the night before, and then through the night, her liver couldn't keep up with producing sugars, so it was breaking down all these fats and proteins and cranking out ketone acids in her body. She looked like she was totally drunk. But it was actually her nervous system shutting down because of the acids. And then these last two here, long-term starvation. And usually you see these more in underdeveloped countries, but it happens in the United States. But marasmus and Korsakoff, and there's what they look like. So typically with marasmus it's like 18 months and younger. With Korsakoff, it's usually older. But in both situations, what's happening is that they have protein deficiency. They're not getting protein efficiently, and then protein deficiency. There are different causes overall, but over the big picture is the protein problem. Who's going to say something? Yep, both of them. With this one, this is Korsakoff, and that picture's in the way. You can probably see from the slide. What do you notice about their feet? They're big, right? So the body's really tiny. Look at those legs. Feet are big and abdomen's big. The abdomen's big because the liver is actually inflamed. The liver's huge. It's not because they have a big belly with lots of food. It's because the liver is so swollen and inflamed. It's kind of like rats. When rats get sick, their belly gets really big because their liver usually swells up. I don't want to bring a rat to humans, but anyway. So that's what's happening here. There you can see the liver has it swollen, which is starving. But with this one, the liver is just thinning out. And the liver is not producing its things like proteins efficiently, which explains what's happening down there. Edema. Because they're missing the proper proteins in their diet. So fluids leak out of their blood, and why the feet? Gravity, pointing down. So, Korsakoff and marasmus. Okay, when you look at liver disorders, they usually group it into one of three things. Either pre-hepatic, which means going up to the liver, intra-hepatic, which means within the liver, or post-hepatic, something right afterwards. And so I kind of grouped it up a little bit like that too. Pre, intra, and post. And then you can see the hepatic portal system coming up and through. All of the blood flow from the GI tract coming up and through here, even the stomach, you can see. Coming over and then up into the liver. And then from the liver it goes into the renal cave and up. Right. So the most important ones, you probably want to make a little mark by ascites. I have a whole slide for that. Splenomegaly, what's it telling you organ-wise? Spleen, and what's it saying about that? Large. Yep, so something's going on in the spleen. Either you're breaking down way too many red blood cells, maybe there's an infection. There's something going on in the spleen, and it gets enlarged and everything gets backed up a little bit. And then varices or distended veins. I'll show you some pictures of that too. And I guess all of these have a slide for hepatic encephalopathy too. So hepatic's referring to what organ? The liver. How about this? It's the brain disease. Yep, so it's a brain disease caused by the liver. I'll show you that. But here's some of the signs that you have portal hypertension. You're not getting good flow through the veins. Things like hemorrhoids. And I didn't make this slide because that's a really interesting one with completing in the underwear. But So ascites, here you have that swollen abdomen, all the veins are distended. And here you see veins sitting along the esophagus. I borrowed it. I'll show you the one. So there's a picture of ascites. And ascites because the fluid's actually building up around the peritoneum. So in the abdominal cavity, you got lots and lots of water. And no, you can't just take a needle and go back down the side. So things like diuretics would actually help. But ascites literally means bag-like, and it looks like they have a bag of fluid in their abdominal cavity. Right. Hepatic encephalopathy. Your liver's not working, so what's the liver's main function, one of the main functions? What automatically pops in your mind? Detoxify things. So if these toxins start accumulating, they go to the brain, they start accumulating in the brain, and they cause actually like hallucinations. So really abnormal behaviors. They might get erratic heart rates because of the way it's affecting the brain. They hallucinate. Sometimes you get the flapping tremor where their hand will actually twitch and move. What's an EEG? It's the brain machine, right? The electroencephalogram. So you might see changes in there. It may actually cause toxins to build up and cause seizure activity. So it's because of toxins building up in the brain. Normally the liver clears the toxins, but if it can't, then they can accumulate in the brain. Jaundice, and I'm just going to group it into two primary types. You've got hemolytic and obstructive. What's hemolytic telling me the problem is? Blood's breaking down too fast. Why is it causing jaundice? What's in the blood? It's the bilirubin, right? So inside the blood you have hemoglobin, and the hemoglobin has two major parts, the protein and the heme. What's in the heme? Iron. And the proteins can be turned into bilirubin. So when you're breaking this down, you've got these iron particles that you can transport and this bilirubin particle you can transport. So if you're excessively breaking down blood cells, it leaves way too much bilirubin in the area and turns jaundice. If you want to test this, I know I've said this example on here before, but if you get hit in the arm with a baseball bat, immediately it turns what color? If you walked up and smacked me on the face, it would turn red, right? See, you'll never forget that now. You're imagining, yes. So it turns red. And if you hit me hard enough, why is it turning red, by the way? Because all those blood vessels they're either flaring up or they're actually popped. And now the red blood cells seep in. Later that day or the next morning, what color is that? It's purple. Why? Because the red blood cells are stuck in the tissue and they're now deoxygenated, which turns them purple or bluish color. And then the next day it turns what color? Kind of yellow-green, right? So the yellow is because you're breaking down the iron and you're breaking down the heme or hemoglobin into bilirubin, right? So you've got all this bilirubin accumulating, which makes it turn yellow. The green is because some of it's still purple, some of it's yellow, so you get this interesting, it's like mixing colors. The light bounces off and gives it kind of a greenish hue. But that's hemolytic. The other one, obstructive jaundice. So you can think of it as affecting the actual liver itself. Does this have to be the liver? No, this could be anywhere in your body. You could have an internal bleeding somewhere and get that. But with obstructive, it's something about the passageway through the liver. Either it's inside the liver or it's outside the liver. Intra versus extra. Let's say you have cirrhosis of the liver. Your liver's not processing things it should be, like bilirubin. You can't get rid of it. If it's extrahepatic, think of it as that blood's not getting into the liver efficiently. It's outside. And this is general.
Is it just localized to a certain area?
Wherever the damage is. So I can't say it's more specific. The other two are revolving around the liver not doing its job properly. Where hemolytic. The what can you see? Oh, yeah, it can be. Yep. With any of them. And somewhere on here it says, oh yeah, there it is. No one test can differentiate between the various types because how does the bilirubin travel through the blood? So it makes it hard to isolate where it is. So you actually have to extract and take samples and get things like urine. So usually it's the light colors of the body or the places that have a lot of blood flow that you're going to see it. Like the whites of the eye actually start turning yellow because, well, you can see the difference there. And I just put the flow chart from the book, but. And the next one, hepatorenal, saying hepato is liver and the kidney. Yep. So between the liver and the kidney. It's the liver or the kidney having problems, which they affect each other. Oliguria means that proteins in the what? Urine. Yep. So proteins in urine. What's interesting is that both the kidney and the liver help you get rid of what chemical we just talked about. Well, I'll give you a hint and make your urine turn yellow. Bilirubin, yep. So you modify the bilirubin and then you can turn it, make it water soluble and urinate it out. Like urobilinogen, but that's not on there. So this kind of revolves around your ability to make and keep proteins and make and keep water. If you don't make proteins for your blood, can you keep the water in the blood? Nope. So it's going to seep out in the tissues, and it's also going to be cleared faster by what organ? The kidney. If the kidney's backed up, let's say you make way too many proteins, why would it cause the kidney to get backed up? About it. What do you remember about the kidney and proteins? It can plug up those little tiny holes, right? So if you make too many proteins, they can actually plug up those holes in the kidney, causing kidney failure, which we'll talk about in the renal section. And then it makes you do what with your blood volume? Can't pee. Volume goes up, causing what to happen to blood pressure? Yep. And then just the opposite, if the kidney loses way too much, you can actually get hypotension. Too much volume.
Oliguria. What's in urine?
Protein in the urine.
Protein in urine.
Protein in the urine. Yep, oliguria. And if protein goes in the urine, what chases it? Solute. Water. So if it's oliguria and it's protein seeping into the urine, then you're going to get loss of water, loss of blood volume, and then hypotension. And then if it's the kidney, which we'll talk about in the kidney section, being plugged up, then you can't get rid of the water. Right, viral hepatitis, this is kind of a summary or preview slide. When you look at it, hepatitis A was formerly known as infectious hepatitis, but what do you know about hepatitis B too? It's also infectious. So it's kind of like diabetes. We used to call it juvenile diabetes and adult onset. The lines are so blurred anymore. Thank you, McDonald's. Okay, so what you need to know about hepatitis A is, with hepatitis A, what you usually find are places that are really unsanitary. Like where you see countries where they're all bathing in the water and stuff. What's the major river through India? It's Ganges. Yeah, and so every time I see the images of that, and they're like, oh, it's a religious river, I mean, and all of that, and I'm thinking, yeah, because I could totally imagine taking the life, you know, or it's going to make you really strong. You're either going to die or you're going to live, you know, live to tell about it. But definitely, you're going to see things like hepatitis floating through there. All right, so things like food and water contamination, bathing in streams, drinking out of streams, stuff like that. And then hepatitis B, you get blood infections, bad needles. How many people had to be, when you went here, do you have to get vaccinated for A and B, or just B? B. I remember if they offered a vaccine, I always take it like that. Except the flu. I never wanted the flu one, and now I have to take it. I don't know. Okay, another way you can get it is from parents. Well, I shouldn't say parents. It's mom. It's mom's fault. Moved on from mom to baby. What is hepatitis? Is it a bacteria? It's a virus. Yeah. So viruses are teeny tiny and they can slide right across the placenta. Next one, hepatitis C. How do you usually hear about hepatitis C? How do they usually get it? When you hear about it in the celebrity magazines, it's always because of sharing needles, sex, or tattoos, right? Like where you always hear about it. Something revolves around needles, sex, and tattoos. Two-time, really. Now, what's kind of interesting about hepatitis is just because you get hepatitis doesn't mean you'll have liver failure. So it's not definitely saying that you're committed to a life sentence, you know, like death at a certain age. They find there's some genetics that people that get infected with the disease, they never are having liver problems. We just haven't figured out why that is yet. So only about 50 to 80% actually result, that's about 50 to 80% too many, but result in chronic hepatitis. And then D, E, and G. And I love talking about E as an example because it goes fecal to oral transmission. When you go into a restaurant and you hear about a hepatitis outbreak in a restaurant, hepatitis E. It could be hepatitis A too, but usually you hear hepatitis E. And the moral of the story is don't eat poop. People, when they work in they go in the bathroom, that's why you see the sign on the wall now, right? That wasn't there 20 years ago, but maybe 30 years ago. I don't know. As people go in, they go to the bathroom, they wipe things, and then they go right back out and prepare your salad. Think about that next time you eat a salad. You should eat a steak. They cook that, right? So if they touch the steak with their bare hands, you just killed the stuff on the surface. Think about sushi a little bit. Right. Let's see. So those were the biggies. A, B, C, and E are actually the more common ones. And then hepatitis, this is actually the transition phase, but I'm not going to make you memorize that. It goes just like every other viral infection. You have this incubation period where the person has no idea what's going on. You know, they have it. Could they potentially spread it? Absolutely. They had no clue. It's just like AIDS. They get it, and then if they get it by sexual transmission, they can be carrying it around for like 18 months without even knowing that they have it. Right? It doesn't even show up necessarily on a HIV test. It's an incubation phase. It's just like it sounds. It's growing and it's incubating. And then the prodromal, they also call it pre-icteric. Icteric means hit. So it means before the big hit. This is usually when they're right in the transition where they're starting to feel symptoms. Maybe they feel a little malaise or a little tired, or a little sleepy. And the icteric phase is when the hepatitis actually hits. They start having decreased proteins in their blood. They start having problems retaining water or water balance. They might get some of that hepatic encephalopathy, like they start having issues with their brain. They start getting flu-like symptoms. Maybe they hallucinate a little bit. They're starting to really come out. It's the hit. In the recovery phase, they start coming back to normal. And it just keeps happening over and over. So icteric recovery, kind of like when we talked about MS. You've got the big symptoms that pop out, and then you come back down a little bit. And then fulminant just means that it's gone to the severe stage. We've actually done some permanent damage. I'm going to go to cirrhosis. In cirrhosis, you always want to think scarring of the liver, but technically the liver doesn't scar. So cirrhosis is actually when you start developing fibrotic areas all over the place, and those little hepatocytes don't work as they normally do. So your liver function just keeps getting worse and worse and worse. I love the little martini guy. So as you start developing this fibrosis, you can't circulate things through the liver, everything's backed up, it can't store properly. If it does store something, a lot of times it doesn't release it, like nutrients, glucose, amino acids, fats, vitamins, minerals. Liver's awesome because it has lots of minerals, lots of metals in it, like iron, has calcium in it, has a lot of nutrients. Unfortunately, it's like the oil filter of the body, so it also has a lot of toxins in it. Delicious. So inflammatory disease causes fibrotic nodules, backs up flow, and doesn't work properly. And then here's just an example of the progression. So you can see it going from left to right. Normal, so it's getting a little bit fatty, it's retaining fats in there, and then it starts becoming a cirrhosis liver. Yummy, yummy. And then bile is made in the liver. What's bile do? Yep, it helps emulsify fats. Where's it stored? In the gallbladder. So the reason I'm pointing this out are the things that are going to be symptoms are going to be they're not going to process water as efficiently anymore. Fat. Yep. If they take a drink, what's going to happen? A normal healthy liver will take the alcohol and break it down. What's going to happen to these people? They take a drink and they get sick. They start feeling really sick and nauseous from it. And I'm not going to ask you about the process, but if you want, you can see how alcohol affects things. Like it causes. Remember what the other name for oxidative stress was that we talked about before? Free radicals. Yeah, reactive oxygen species. So it causes these free radicals to go in and they start destroying the cells in the liver. And then those cells don't work properly anymore, and it just causes one problem after another. But that's way more than we need to talk about with limited time. And then what do you call these things? Gallstones. So here's the gallbladder, and you see all the gallstones. All they are super condensed bile. So they're big wads of cholesterol and bilirubin, which explains their color, which is kind of yellowy, right? Yeah. So lots of cholesterol, lots of bilirubin packed together, condensed, and then it just builds up. So they can become compacted. Can you live without a gallbladder? Yeah. But you have to change what about your life? Yeah, your diet. So lots of theories on how they come about, and you can see genetic predisposition, things like Native Americans get more than the average player. So we know there's some genetic history behind it. Might be the way your body handles cholesterol. So it's amazing because it's like smoking. Some people smoke their entire life and never get lung cancer. Some people smoke for 3 years and poof, they have lung cancer. Some people can have a really crappy, high cholesterol, I eat a pound of bacon every day and I'm just fine kind of lifestyle. Other people, they eat, 3 slices of bacon once a week for a year, and then suddenly they have gallstones. So there's a lot of factors that go into it. It revolves around that bile and that accumulation of bile. And there they are. And every time I look at these things, it makes me want to eat a little bit better. When we see kidney stones, it makes me want to drink more water. Probably not going to happen, but it scares the hell out of me. And then next, accessory organ, the pancreas, and pancreatitis. The pancreas is important because it has 2 major functions, endocrine and exocrine. What's endocrine mean? It releases hormones. Exocrine means it secretes these enzymes for digestion. So pancreatitis causes lots of problems. What's the main hormone that you think of with the pancreas? Insulin. Yep. So there's insulin, there's glucagon, there's somatostatin, different ones we'll talk about with endocrine. But you can't release those properly. So what's the first thing you're going to know you can't maintain properly? Blood sugar levels. And if it's exocrine, you release proteolytic enzymes, lipase, and amylase. What do those 3 things do? Break down carbs, fats, and proteins. So pancreatitis causes digestion problems, absorption problems. It causes acid-base imbalance inside your GI tract because it also makes a very basic fluid. And then it's going to cause hormonal issues like insulin problems. So by diabetics, either diabetes or diabetic-like symptoms. And pancreatitis, something happened that went wrong. It could be activation of those enzymes in the pancreas where they actually eat your own pancreas. And a lot of times to test for pancreatitis, they'll actually take a blood sample, and if they see those enzymes in the blood, it's a big no-no. So remember, these things eat proteins. What's in your blood that's made out of protein? Everything. Right, red blood cells, white blood cells, platelets, they're like all proteins, albumins. So it causes lots of problems. And then you can see some of the symptoms. When it says epigastric pain radiating to the back, what kind of pain is that actually called? Or referred pain, yeah. And then fever and leukocytosis. So what's happening here is that it's basically telling your body, hey, there's something infecting the blood. So your body's reacting to it. It's actually your own body that's the problem, so it causes a little bit of fever. You start cranking out the white blood cells. And then hypotension and hypovolemia. What's it talking about? Hypovolemia means decreased blood volume, which is automatically going to lead to lower blood pressure, hypotension. So when those enzymes get along the blood vessels, they act like histamine, which did what? Cause that vessel dilation and capillary retraction, the opening. So it does the same thing. You get more. So what else would that cause? Like fluids moving out. Edema. Yeah, so it will cause edema symptoms too. And then chronic pancreatitis can be lots of things, but alcohol seems to be the theme of the day. So. But alcohol gets in your blood, it goes anywhere at once and starts disrupting membranes of everything. And then cancer can hit any one of these different places. And what's interesting is one thing that you can do environment-wise can cause all of these cancers. Smoking, right? You knew it was coming. I had to put it in there somewhere. But why would it cause GI tract cancers? Why would smoking cause GI tract? It's supposed to go in your lungs, right? Because it remains like in the mucous membranes, and where's the mucus go? Down into your esophagus, into your stomach, into your small intestine, large intestine. It introduces all of those toxins. It's like those people that say, well, I only smoke when I drink. I've already covered this, right? They're twice the idiot. So, because what they did is they took those toxins that maybe they're water soluble, which doesn't get absorbed very well, and then introduced what to it? Alcohol, which is a solvent. It's a lipid-loving solvent, and it takes those toxins and introduces it all the way down the GI tract. So, if you're going to have a bad habit, make it one or the other, but not both at the same time, I guess. And then you can see all the little black dots represent the common cancer locations. So you can see over here, this is where a lot of activity is happening. A lot of destruction, a lot of damage. Things like Helicobacter pylori. Up here, what's this going to cause? We get a cancer up there. Cause reflux, so GERD, gastroesophageal reflux disease, or it's going to obstruct, which caused dysphagia, right? So swallowing, where they can't swallow appropriately. And then we kind of talked in the cancer section about polyps and how they develop. Polyps develop because what's happening to those cells? What's the M word that they're doing? They're mutating. Yeah. So you get these series of mutations that slowly change the whole thing. And then you can see percentage-wise in the colon or the large intestine where most of the cancers are happening, or actually in the rectum. So, colorectal cancer. Who was the famous actress that just died of this head 2 years ago? Farrah Fawcett, thanks. I can picture her in those like 1970s posters, but I couldn't remember her name. Okay.